السلام عليكم طلبتنا الأعزاء. محاضرتنا لهذا اليوم هي Respiratory Distress Syndrome, or what is called the hyaline membrane disease. It discusses the respiratory distress syndrome and its etiology, features, diagnostic tools, and how do we prevent it and how do we manage it. And number two, we would discuss the neonatal birth injuries to various parts of the body. Hyaline membrane disease occurs in 60 to 80% of those infants less than 28 weeks of gestation, and it occurs less around 15 to 30% of them for those delivered with a gestational age 32 to 36, and it occurs in about 5% of those delivered with a gestational age above 37 weeks of gestation, and it is very rare at term. Its incidence, is inversely related to both gestational age and birth weight. That's to say, the more the gestational age, the more the birth weight is, the less is the frequency of occurrence of this condition. There are factors which are commonly you are asked about that increase the risk of occurrence of the respiratory distress syndrome, which includes prematurity, maternal diabetes, multiple births, cesarean sections, precipitated delivery, asphyxia, cold stress, and history of previously affected infant in the same family. So these factors increase the risk of this RDS. While factors that reduce the risk of occurrence of respiratory distress syndrome, they include pregnancy with a chronic or pregnancy-associated hypertension of the mother, maternal heroin use, the prolonged rupture of membranes, and antenatal steroid use. These all decrease the frequency of occurrence of this illness. The etiology of respiratory distress syndrome is related to decreased production and secretion of surfactant, which is manufactured in type 2 alveolar cells and it is secreted into the alveoli. It helps to maintain the surface tension and to reduce the surface tension and maintain the alveolar stability. So it prevents the alveoli from collapsing at the end of expiration. That's why these babies are prone for atelectasis. The mature levels of surfactant are present at gestational age of 35 weeks and more, and the synthesis of surfactants is suppressed and diminished in cases of asphyxias, hypoxemia, pulmonary ischemia, hypotension, and cold stress. In this diagram, there are factors which are contributing to the formation of the hyaline membrane disease in the newborn. In cases of prematurity, cesarean sections, intrapartum asphyxias, familial predisposition, and acidosis, there will be progressive atelectasis due to deficiency of the surfactant, with the resultant hypoventilation and the initiation of hypoxia, hypercapnia, and acidosis. All they predispose to a hypotension shock and hypovolemia and a pulmonary vasoconstriction, which results in alveolar hypoperfusion and impaired cellular metabolism, and again, they run into a vicious circle. Regarding the clinical manifestations, usually these babies develop tachypnea and shortness of breath soon after delivery, or it might take hours in larger preterm infants. Yet the late onset of tachypnea should suggest another reason for it. And some of these babies, they might have history of resuscitation after birth. So these baby would develop grunting respirations with intercostal and subcostal recessions, with flaring of LNASI, and duskiness of the lips even might be noted. Cyanosis might develop, and it's often not responding to oxygen administration. On examination, the breath sounds could be normal or bit diminished with harsh tubular quality. Sometimes we might find fine crepitations over the lung bases. However, there is nothing specific about the findings. In advancing cases, the blood pressure would fall down and they would develop fatigue, increasing cyanosis with increasing pallor due to signs of shock, and grunting disappears due to diminished respiratory efforts. Furthermore, apnea and irregular respirations would develop, and they are considered ominous signs and they required medical interventions. Usually, symptoms they peak within 3 days, and after which a gradual improvement is expected. Improvement is usually heralded by the spontaneous diuresis and the ability to oxygenate the baby at lower levels of oxygen or tensions of the ventilator pressures. Regarding the outcome and death, death is rare on the first day of life, yet it usually occurs in between day 2 and day 7, and the causes of death they are either due to alveolar leak in the form of interstitial emphysema or pneumothorax, or it could be due to pulmonary hemorrhage or due to intraventricular hemorrhage. Diagnosis of this illness depends on the clinical course of the illness and the X-ray findings. There is nothing actually pathognomonic of this illness apart from finding of fine reticular granularity of the parenchyma and air bronchograms. The X-ray should be taken not less than 6 to 12 hours after the onset of the illness to have some findings might be encountered in them. Number 3, we depend on blood gas and we find features of hypoxemia, hypercapnia, and metabolic acidosis. Regarding the differential diagnosis, there is a wide spectrum of illnesses might mimic this condition, including the sepsis, the cyanotic congenital heart diseases, meconium aspiration, persistent pulmonary hemorrhage, diaphragmatic hernia, pulmonary lobar emphysema, and transient tachypnea of the newborn, which occurs usually in more mature babies. Regarding prevention of respiratory distress syndrome, one should avoid the unnecessary cesarean section deliveries. Number 2, we should avoid premature deliveries. Number 3, we should administer betamethasone to women 2 days prior to delivery and those with gestational age of 24th to 34th week of gestation, which significantly reduces the incidence and the severity, mortality, and morbidity of the respiratory distress syndrome. Repeated doses of betamethasone are to be administered weekly until the 32nd week of gestation to reduce the neonatal morbidity and the duration of use of mechanical ventilation. Number 4, the use of CPAP. The CPAP is the continuous positive airway pressure ventilation, which is used and proved to be as effective as the use of prophylactic or early use of surfactant, which is the approach of choice for the management of preterms at risk of respiratory distress syndrome. The treatment of RDS includes number A, the supportive treatment, which is admission to a neonatal intensive care unit. Then we apply early supportive care of the low birth weight infants, which includes treatment and management of acidosis, hypoxia, hypotension, and hypothermia. Next, we should have careful monitoring of the vital signs, including the heart rate, the respiratory rate, the blood gas, and the acid base values, in addition to monitoring of the electrolytes, the blood sugar, the vital signs, and the hematocrit. Next, we deal with the administration of fluid and delivering calories to the baby in the form of the nutrition and electrolytes, and we should control the fluid volume given and to be increased gradually. After the supportive measures, we should apply oxygen, and the oxygen should be humidified, and we try to reach a level of arterial oxygen concentration of 91 to 95% of saturation, and to minimize the risk of high oxygen tensions and the ocular effects of it. If the oxygen tension cannot be maintained and reached above 90% of saturation, in the inspired oxygen concentrations in between 40 and 70% or greater, then the CPAP should be initiated. The CPAP, as we said before, it is the continuous pressure airway pressure ventilation. It's given at a pressure of 5 to 10 centimeters of water by nasal bronchs, and it will result in a sharp rise in the partial oxygen tension in the circulation. Infants with severe respiratory distress and with those having the complication of persistent apnea, they might be in need of assisted mechanical ventilation to control this condition. After the supportive treatment and the oxygen administration comes the role of surfactant, which is applied during the first day of life through an endotracheal tube in 2 to 4 doses. It would reduce the severity of the respiratory distress syndrome, and these doses of surfactant in very low birth weight infants will improve the survival of these newborns, and it would reduce the incidence of pulmonary air leaks. Regarding complications of respiratory distress syndrome, they include number one, the complications which are related to tracheal intubation in the form of asphyxia, cardiac arrest, development of later on subglottic stenosis, bleeding due to traumatic intubations, persistent hoarseness of the voice due to injury of the vocal cords, the development of stridor, persistent one maybe, or transitory, or edema of the larynx. Also, we have risks of catheterization of the umbilical artery in the form of either vascular embolization, thrombosis, or perforation, or risks associated with cannulation of the umbilical vein and the following infections, or probably later on portal hypertension. Number three is the bronchopulmonary dysplasia with the chronic dependency on oxygen therapy. The entity of neonatal birth injuries, it is not uncommon in newborns. It might be in various presentations. They could be either in the form of erythemas, abrasions of the skin, ecchymosis, subcutaneous fat necrosis due to use of forceps or vacuum assisted deliveries, the ventus, or they could be in the form of subconjunctival hemorrhage or retinal hemorrhages. And here is a photo of a subconjunctival hemorrhage in this baby. Fractures might develop in the skull in the form of linear fractures, which are most common due to pressure of the maternal pelvis on the skull of the baby, or they could be depressed fractures due to the use of forceps during extraction of the head of the fetus, and the affected infants may be asymptomatic unless it is associated with an intracranial bleedings and injury which might require evacuation of the hematoma. Of the common cranium injuries, we have an example of caput succedaneum, which is a diffuse and sometimes ecchymotic and edematous swelling of the soft tissues of the scalp, which is related to the presenting area, which is usually the vertex at delivery, and it might extend beyond the midlines or the cranial sutures, and it takes a few days usually to disappear. Caput succedaneum might be associated with molding of the head and overriding of the parietal bones. And this condition, it takes weeks to disappear, and they become more evident when the caput disappears or recedes. This is a photo of a baby complaining of caput succedaneum and of the presenting part, which is the vertex, and we find the pitting edema manifested on the left and the right photo. The other entity of cranium injuries is the subperiosteal hemorrhage, which is called the cephalhematoma. It is usually limited to the surface of one cranium bone. That's to say, the suture lines are the boundaries of these bleedings, and it is a deep-seated bleeding in between the bone and the periosteum. It occurs in 1 to 2% of live births and it is not associated with any discoloration of the skin above it, and this swelling is usually not seen soon after birth, but it takes hours to develop because of the slow process of oozing of blood in this limited area. By time the cephalhematoma become a firm tense mass with a palpable rim due to absorption of the blood from it, which is limited to a well-demarcated area over a single skull bone, and most of them they are resolved within 2 weeks to 3 months, and these depend on their size. This is a photo illustrating uh, the area which is involved in the formation of the cephalhematoma, which is deeply seated in between the skull bone and the periosteum, while the caput succedaneum is a superficial soft tissue edema related to the presenting part. By the end of the second week of life, they start to calcify, and there will be a resorption of blood from it, and few cases might remain as a bony calcification, which might be detected on X-ray as a widening of the diploic space. 10 to 25% of cases are associated with these linear skull bones which do not need treatment. This is a photo of a bilateral, well-confined cephalhematoma to the parietal bones. All cephalhematomas might give the sensation of a central depression, which might suggest a fracture, yet it is not, and they usually disappear by time, which takes months or weeks or more to disappear. These cephalhematomas, they do not need any treatment, no blood aspiration, yet they might exaggerate an already present hyperbilirubinemia due to absorption of the extra blood from this space. One of the most important conditions of brachial palsy is the Erb's Duchenne palsy. It is limited to C5 and C6 nerve injury, and the baby would lose the power to, number one, abduct his arm from the shoulder. Number two, he would lose the power to rotate his arm externally. Number three, he would lose the power of supinating his forearm. So the characteristic position attended by the baby is adduction and internal rotation of the arm with the pronation of the forearm. So by examination, these babies, they would retain the power of extension of the forearm, but they would lose the biceps reflex because it is C5, C6 reflex. The Moro reflex is absent on the affected side. The power of the forearm and the hand grasp is preserved unless the lower part of the plexus is also injured, and the presence of the hand grasp is favorable prognostic sign. It is said that loss of the distal hand actions is worse than the proximal ones. The other entity of brachial palsy is the clump's palsy, which is related to injury of C7, C8, and T1, which results in paralyzed hand and ipsilateral ptosis and meiosis, which is called the Hernon syndrome, if the sympathetic fibers of the first thoracic roots are affected. This is a photo of an infant with unilateral Moro reflex, which indicates a brachial palsy of the left hand. It is an asymmetric Moro reflex. Diagnosis is made by the aid of MRI to demonstrate the brachial plexus nerve roots, and we can find the rupture or the avulsion of the nerve root. And if it was in the form of neuropraxia, that's to say edema of the nerve root, then which it carries a good prognosis and it would heal within a few weeks to months. And or if this is related to laceration of the nerve root in the form of a neurotemesis, so a permanent damage is expected and a microsurgery is indicated. And as it is, I said before, that in general, paralysis of the upper parts of the arms has a better prognosis than paralysis of the lower parts of it. Treatment of brachial plexus palsy includes partial immobilization to prevent the development of contractures, so that the arm should be assisted and abducted 90 degrees with external rotation at the shoulder and full supination of the forearm and a slight extension of the wrist with the palm turned towards the face. This is the resting position of the upper limb. It is to be fixed like this in the first 1 to 2 weeks of life. In cases of lower arm and or hand paralysis, the wrist should be supplanted in a neutral position and padding placed in the fist to prevent flexion of the hand. Number two, there should be gentle massage and a range of motion exercises to be done and to be started within the 7th or 10th day of life. And if the condition persists by the 3rd or the 6th month of life, then neuroplasty is to be conducted. The other variety of nerve injury is the phrenic nerve injury, which is related to C3, 4, and 5 cervical nerves, and it results in cyanosis and irregular hard respirations early in life, and on a fluoroscopy there is a paradoxical movement of the diaphragm. While the other entity is the facial palsy, which is related to seventh nerve injury, either by pressure on the nerve, which is the peripheral nerve end of it, or the forceps pressure during assisted hard vaginal delivery. Now we come to injuries of the bones in the form of fractures. The commonest bone to be affected is the clavicle, which is fractured usually during labor, and it's usually vulnerable because of the difficult labor of the shoulder in vertex presentations or in the extended arms in breech deliveries. Findings in clavicle fracture including number one, that the baby doesn't move the arm freely. It manifests as what is called pseudo-paralysis on the affected side. Number two, there might be crepitus over the bone with irregularity, which could be palpated, and maybe discoloration. The motor reflex on the affected side is absent, and the prognosis is usually excellent, and treatment, if any, consists of immobilization of the arm and the shoulder on the affected side because it is painful. Otherwise, it doesn't need any actual treatments. Some clavicle fractures might be unnoticed and they will manifest themselves as a callus or a palpable mass over the clavicle seen weeks after healing. Fractures of the humerus might be encountered in difficult labor and they would present with unilateral motor reflex due to inability to move the arm of the affected side. The femur bone might be fractured, which results in shortening of the lower limb, limitation of its active movements, with a painful passive movement with external rotation, and there might be a mass of big hematoma, and even that might present with anemia due to hematoma collection.